What's up, FRT community? Welcome to episode 2 of RTalk. I'm joined today by Teresa Griego, and you're not going to want to miss her words. Let's dive in. What's up, future respiratory therapists? Respiratory Coach here with you. We got another interview for you with a lot of information that you're going to learn from another experienced respiratory therapist. Today, we're joined by Teresa Griego. And Teresa Griego is believe it or not, a respiratory therapist times 30 years and is currently working and focusing primarily on or in the neurocritical care unit, which is what her current specialty is. And she also just recently got into teaching, and she has some words for wisdom to share with you today. So Teresa, welcome. Thanks for being here.
Thanks for having me.
Yep. So let's talk about something here, Teresa. Why do you love respiratory therapy? What's so great about it?
Well, I love patient care. I love humans in general. I like talking a lot. I like hearing people's stories as a general rule. And so I chose patient care because honestly, I was so young when I started, because you heard in my intro that I've been doing it for 30 years, which is really cool. They let me start when I was 5 and everything. So, but I chose it because I was in trouble for talking my whole life. So I decided I needed to do something where I could make a living and not get in trouble for talking. So patient care came into my decision making. So as a respiratory therapist, though, there's no single practitioner in the healthcare setting that has more time with the patient, valuable, true time, where you're getting to hear not only about their healthcare issues, but in general, what's going on in their life. And you see how it's affecting the families. You're with the families more than anybody else at the at the bedside. So I'm passionate about making that time be the most valuable for that patient experiences to prevent negative outcomes for their healthcare stay, but more importantly, positive outcomes.
That's good stuff. I can't argue with it. I mean, it really is good stuff, Teresa. I don't think a lot of students who get into this really think about it maybe from that perspective. But what you just said really completely describes what a respiratory therapist is. And I like the way you put it in the perspective of time at the bedside, because time at the bedside is ultimately what comes down to being important. And unfortunately, we don't always take advantage of that time at the bedside, but nonetheless, that time is still valuable, and I appreciate that. So here's what I want to ask you, because here's one of the things, and for everybody watching right now, much like the last video you may have seen, this video is 30 minutes in the making. And so I was talking to Teresa, we were talking on the phone, and I said, hey, let's stop. Let's just get off. Let's go get on Zoom. And we stopped and we went off and got off on Zoom, right? And here we are now talking. And so what you're really going to see here is just the conversation that me and Teresa have, and hopefully you learn something from it. Teresa, one of the things that you have brought into my life over the last 12 months is this idea of research. Why is research so important to you in regards to respiratory therapy?
Research is so important. It's not the research, it's the evidence from the research that's so important to me. I'm a scientist by nature. And so that in itself speaks volumes, whether you are a physician, a respiratory therapist, a nurse, work in a microbiology lab. We do things in a science world based on evidence, pro and negative. There's sometimes we do things because there was a negative outcome, so we do the opposite of that. We do a different way from that. But all of our medicine that we do at the bedside, respiratory care, is based on whether it works or it doesn't. It either has evidence to show that it is bettering outcomes for respiratory therapy, or not respiratory therapy, for respiratory health, or it doesn't. And so research came to my life most recently because I decided to pursue a master's in respiratory care after all these years. And people say, why in the world would you do that? You're not going to make more money. You're not going to have anything come from it. It's only going to cost you. Well, I want to tell you that when I went to school to begin with, it cost us. And the idea as to whether or not it ever pays you back is basically dependent on what you do with that education. So there's times where I have made monetary advancements based on my decisions, and there's times that I grow in personal growth, which is way more valuable in my life than money, although money is necessary, definitely. But I realized I didn't know anything about research. I thought that somebody up in some ivory tower somewhere was doing all this phenomenal research, and I was just dealing what was given, the cards that were dealt me, basically. What I realized is all of our research, not just in respiratory therapy, across the board in the United States, is lacking. Basically, the last 30 years of our life, we spent a good majority of it in war and different things like that. I'm not here to talk about political anything. The reality is funds were diverted from other directions besides the National Institute of Health, where research is happening in our country. And so please don't, I'm not talking about politics. I'm just saying it doesn't matter. There just wasn't any research. And the reality is, it is really my responsibility as a leader in this field, as someone who wants the best for patient outcomes, that wants to see the respiratory therapist encompass the word of practitioner the way it was always intended to be. That's why we were called practitioners. We were always intended to go into an environment of patient care and practice those concepts, those modalities, not just give modalities, but see how the best modalities fit the patient and how you can have better outcomes from that. Well, unfortunately, because we get very caught up in, well, the physician has to give the order. Absolutely, they do. I'm not suggesting that practitioners go in and start writing orders, but I am suggesting that the intent was for you to be an important cog of that wheel to make sure that your providers are understanding the whole respiratory picture. Remember, they aren't at the bedside as much as we are. So I've never had an issue going to any practitioner and telling them, I was taking care of your patient's respiratory care today, their respiratory health, and I realized that this modality was not working for them as well as I believe another modality would. I would like to work with that patient in that manner. You know what they heard? I want to work with their patient to have a better outcome. If someone has had an issue of that in their practice and someone's told them no, I'd love to have that conversation. But be careful. Make sure it's not that you went and asked for something to change without giving reasons. Because I promise nobody in life asks for something. Forget medicine. You don't go up to your children. Your children don't go up to you and ask for change without understanding why you're asking for the change. Where did we start? What was the question?
No, that's good. That's good. No. You answered the question. It was about research and why you're so passionate about it. And I think you illustrated that. Anybody watching this right now, you can tell somebody who can talk on and on and on and bring research into evidence, into practice, into physicians, into communicating with physicians. This is a person who values research and values evidence, and I can't argue with her. Like I cannot argue with Teresa on just about anything because she always brings it back to evidence, and I love it. It's so good.
I think we always come back to why is greater than how.
Oh yeah, yeah, yeah.
Right?
Get you some merch.
I know, right? I mean, really, that's how we really started in some of our conversations.
Yeah.
Anybody can do a task, even if it's not in your specialty, to be fair, right? My children, 2 out of 3 have asthma and have been taking a nebulizer since they were knee high to a grasshopper. Okay. So that is not a respiratory therapy valued skill to be able to put medicine in a cup, right? To know why and when you should put that medicine in the cup, that's the value.
Yeah, absolutely. Talk to me about this real quick, because you have an interesting approach to unnecessary therapy. You really do. I think you're the first person I've ever talked to that talks about unnecessary therapy in a manner in which you approach the physician from. So tell the future respiratory therapist community out there why somebody should never approach a physician with just DCing therapy. Why can't I go to the doctor and say, hey doc, this person doesn't need albuterol Q4 SVN, DC it please. What do you think?
Well, it's kind of a large answer, like all of my answers, I think. But well, number one, let's talk about if it's anything in your life and you have to be responsible for it, right? Maybe you've had a child, now you're responsible for this child for the rest of your life. So there's a lot of box checks we do in life to make sure that we are taking care of the kids right, especially when you're new, right? You go and you find the right pediatrician and you find the right diaper and the right this and this and that. And you have box checks in life to make sure you've taken care of that situation, whatever it may be. Well, your physician's the same way. We have many different specialties that come into play in taking care of the human body while it's inside of a facility we're working. And from respiratory system, your endocrine system, your GI system, your cardiovascular system, right? We could go on and on and on. And do we have different specialties, physicians for each of those specialties, right? We have physicians that are specialists in each field. In the same way, we have practitioners, respiratory therapists, physical therapists, speech therapy, different things where they're the specialist at the bedside. And so when you have a doctor that's ordered respiratory therapy for the patient, it could be there was a valid need for it. There was something that happened and now that patient's better and that situation has changed. But also it may just be a box check to make sure that someone with a licensure and an expert field of respiratory therapy is looking in on that patient. And so while the patient may be on a nebulizer, which we could go into all kinds of non-evidence for that.
Yeah, yeah.
However, let's say there's an order for a patient and they are on, and this happens to me daily. I go in, I receive my patient, I get my orders, and it says Q6 dual neb by handheld nebulizer. There's not, unless they are a status asthmaticus, and some, remember, I work in a neurocritical unit. Unless there's somebody actively wheezing from non-cardiogenic or pulmonary edema reasons, there's no reason that bronchodilator really should be ordered for that patient Q6. But when I go to my physician, I say it this way. I'm taking care of your patient today. I have no ego about that. That person is the head of this team, head of the ship. It's their patient. And I'm on the team and happy to be there. I'm taking care of their respiratory care today, and I don't see that they're having needs for the bronchodilator, but I think I can use recruitment therapy to ensure the health of their lungs while they're here. I think I looked at their x-ray and I can see X, Y, Z. Or I can see they have low lung volumes. So I would like to start an easy PAP therapy to ensure we're having recruitment so we don't have any future oxygenation issues, needs, requirements. And I am never told no. All they hear is I am taking care of their patient in that area of their box check, and their patient's going to benefit from it. And someone is spending time to ensure they're not having any respiratory problems. The number one vital, the first vital to go wrong in patient negative outcomes is the respiratory rate. Wow, right? Woo! So the first thing we do in life is take a breath. The last thing we do in life is take a breath. And the first thing that is imperative for us to prevent negative outcomes is to be monitoring the respiratory rate, which if you're a practitioner, you know, is never really, unless you're in a unit where it's got a lead on it and it's actually counting it for you, which still isn't always accurate. But people aren't recording their respiratory rates correctly. That's why everybody has a respiratory rate of 20 in the hospital, right?
Yeah.
Which if you want to take, let me count you right now for a minute, and you breathe 20 times a minute, really isn't even easy.
Right.
Difficult, right? I breathe probably 8 to 10 times a minute. I mean, I don't need that much for my minute ventilation. So
I think I really like what you're saying here, and I think the message for anybody watching this video is that it's not about the misordered therapy. And that's what we get caught up in sometimes. We say, it's like, why are you ordering all this therapy? Don't go out and try to get all the therapy DC'd. That's not the goal. The goal is to assess your patient and then come back to the physician with a game plan. You got to have a goal in your communication. Your communication should be like, hey, this therapy doesn't meet the goals of this particular patient, yet this therapy will. So
yet I still don't say this one doesn't meet it, so let's DC it. I say we'll still keep it there, PRN, just in case they need it. And there's another reason for that, right? No doctor wants to get a call in the middle of the night,
right,
for a PRN albuterol
right,
treatment that you DC'd that possibly could happen. There's allergies in the air. Maybe that person has a bronchospasm.
right.
Keep it there, PRN. That's why it's there for you. If you need to make a decision as a practitioner to use that, use it. Still, I didn't DC it, even though I had an addition of therapy added.
So I think if I can summarize here real quick, and then we can move on to the next question. I think what you're saying is that you don't ever seek out to DC therapy. What you do is seek out to find appropriate therapy. Is that fair?
Perfect. That's perfectly said.
Okay, perfect. All right. So I do know you just recently in the last 12 to 16 months have began teaching as a respiratory therapy instructor. Tell us a little bit about that journey.
Ooh, it has been, well, first let's start with I started in the year of the COVID, right?
Right.
But even before COVID, I started just like I started my first day of school myself, right? New backpack, new way to go in and look. I started my day out thinking, now what does a teacher look like? I mean, like, what am I supposed to wear? What am I supposed to do? What's going to give me this position of authority all of a sudden, right? Because while you can say you love teaching and you want to educate and you want to perpetuate a field to a higher level, how do you do that? Like, do you go in and be the cool kid? Like, I'm cool with everybody else on the team? Or do I go in like, you know, with my glasses on and very serious? I mean, what is it going to do? And then, thank Lord Jesus that I met an instructor that was tasked with orientating me to the hospital. And so as we went in that day, I was lucky to see that there was no airs about this human. He just threw it out there. He drew on the windows. He did all kinds of things. And what I realized was it doesn't matter what I was supposed to be. I am who I'm supposed to be, right? I mean, this is not a lecture about being who you're supposed to be. It's literally we change different hats in life. We, you know, sometimes I have my mom hat on. Sometimes I'm a respiratory therapist. Sometimes I'm my husband's beautiful wife, I'm, whatever, all these different things that we try to be. And so I was going to try to be the best respiratory instructor I had ever seen, because honestly, I felt like it wasn't available to me the way that I now see it. I wasn't taught what I know. Wow, that's a big statement, right? I wasn't taught what I know. So that's why I decided to do it. So no surprise to anyone, you were charged with instructing me. Matter of fact, my husband even gave me advice that day, like, Teresa, it's your first day. Don't be too extra. Right? He's like, and not that he wants to change me, but it's not always that people receive me fantastically in my profession when I don't agree with what they think. I'm not trying to disagree with people. It's usually people trying to prove their way, and all I can tell them is, I'm sorry, there's no evidence to support that. I understand how you may feel, but there's no evidence. So anyway, that's what he meant about don't go and just be all extra and try to, whatever. So I listened to him, right? You put people in your life and you listen to her. So I went in with my listening ears and watched. And now, probably for a year, I've been mimicking what I saw in those first few days of you teaching. And it's so difficult. It's so hard. I can know so much, but putting it in a way that people understand. People are auditory learners, visual learners. We learned this in our communication classes in our master's program that we're in. Things but boy, when you're in a group of people, some want to learn, some are scared to learn. Maybe it's not the right word. They're timid to say they don't know when they don't know. And then some of them just fake it and then never really learned it. Like they can answer the question, just like I said, I made it through respiratory therapy school. I'm a registered respiratory therapist. I've taken all the board exams and everything that says I'm legit. And still, I didn't know most of what I do today wasn't taught to me in respiratory therapy school. So I am struggling every day. I prepare more for this position that I teach once and sometimes twice a week than I do in any other thing, right? A lot of time goes into the FaceTime I have with those students, and they have no idea. Yeah. I'm just trying to decide how I'm going to let them know that the whole goal of a respiratory therapist is to optimize external respiration so that we can achieve internal respiration, right?
Wow. I didn't expect you to really reveal that much about our relationship, but I do respect you for it. And I'm so glad that opportunity came up when it did. And I'm just glad and grateful to be a part of what you're going through right now. I think there's something here that you just said a minute ago that it actually just reminded me of something. I was going to go to another question, but I'm going to scratch that question. And we're going to talk about something else. There's two things we're going to talk about. What are your thoughts on laziness?
There's no place for it in respiratory therapy, and yet it's taken most of the bus.
Yeah.
Most of the seats are filled with task doers, able to complete the task. Because everybody, when you have a task, right, you make a list, you check it off, and you get done with it. That's how we all do. We go to the grocery store, whatever, right? You just want to check them off and go. And then our field has decided they want to complain about the non-respect they have. No respect is given, right? Yeah. But just like my respect for your teaching, well, I'm sure you probably were born a genius. Your teaching ability came from sheer time, yep, error, ebbs and flows here and there, whether you did well, maybe you tried things that didn't work, so you redirected. And anytime we get a chance in life to watch somebody that's made all the errors before you, well, hell, let me try to learn from you. I don't want to make the same mistakes if I don't have to. Well, that's what the respiratory therapy field has been doing. They have been making the same mistakes and wanting to know why there's not a different outcome. They're not spending the time to improve respiratory health at the bedside. They're spending time to check off a task. Do it, right? I need to spend in here 10 minutes. I spent my 10 minutes. I'm out of there and I'm on to the next thing so I can get to breakfast. It's very important on my 12-hour shift that I eat 2 or 3 meals during that time is the mentality. I don't have time for that. I didn't go to work to go and sit and have breakfast. I'm not suggesting people go hungry either, but they should at the expense of their patient having demise at the bedside because they weren't doing the therapy they should have done. It's lazy. They're just lazy. They want to do the minimal amount to get the maximum pay. And somewhere along there, they thought that equation equaled respect.
I'm sorry, I'm taking notes as we go, as you can tell.
No, that's good.
But damn, that was an amazing statement, what you just said. You just said, I'm going to repeat it for anybody who might have missed it the first time. You know, a lot of times you have to say things a little louder for the people in the back. So let me say it a little louder for people in the back. Majority of respiratory therapists are looking to do the minimum amount of work for the maximum amount of pay and then expect respect on the back end. And it's never going to work. It's never going to work. This is not me telling you this. This is coming from somebody you've never met before, Teresa.
It doesn't work with any equation in life
now, but Teresa's now supporting it. And you know what's interesting, Teresa, is why is it that every time I talk to a respiratory therapist, no matter what position you hold, this is not about positions. And that's what I want to make sure I make clear to the FRT community right now. This is not about positions. This is not about degrees. This is not about nothing. This is about humans taking care of humans. And I am now talking to Teresa. And if you remember, I did a previous interview with JJ, and JJ also said the same similar thing. He said, you want to get your work done. Why? So you could go eat breakfast. Why? What job do you get paid to eat breakfast for? Like it blows my mind. And I don't know about you, Teresa, but it blows my mind. I think it's absolutely absurd. And I'm going to finish with this right here. Again, I had another question for you, but I just thought of something different that you like to say. And I want you to have the platform to say it because you say it the best. So there are probably a lot of RTs out there, especially about to graduate, the class of 2021, the class of 2020, that are getting advice that sounds like this. And you know what I'm about to say. Fake it till you make it.
Mm-hmm.
Tell the world what you think about that statement.
And let me be clear, it's not just in respiratory, it's in nursing. I tell my new nurse grads when I give them, from time to time, you know, when they were first coming on and they're onboarding, then they'll go over the modes of ventilation and go over different things. And I tell them, don't fake it till you make it. That's what everybody tells you, right? Because there is a definite time when you come into the work field when we know you don't know what you're doing, okay? Because I just told you, everything I know, I didn't learn in school. Everything that is important in my therapy every single day, I didn't learn where you are now. So I know when you come in as a new therapist that you actually don't know it all. And I am hopeful every single time you know something I'm going to learn because I'm ready. Teach it to me. That's what I want. But I know that you don't actually know. I know you don't know time management. I know you don't know how all the pieces come together. And I know that you don't maybe know the flow of the heart like you should. I know you maybe don't know why we even give a duonib. What is it even doing, right? What are those two medicines doing? Maybe you learned how to take the test that says that it was a parasympatholytic for ipratropium, but why are you giving it and what does it mean? I know you don't probably remember all of those things. So you have a window in life. And I think this is probably true for almost anything you do in life. There's a window where the more questions you ask, the more you get the respect of the experience around you. Because the questions, the right questions, right? I mean, I hate to say the right questions. They say no questions wrong or stupid or whatever that saying is. Well, come on now. I mean, if you really don't know why you're given a bronchodilator, then that's another conversation we'll have to have. But if you're coming in and asking questions and wanting to know why and can't remember this and all these types of things, boy, I can't have more respect for you because you have the guts to tell me. What happens in medicine is that you fake it till you make it, right? And then you go just long enough that when you don't know it, then you feel ashamed to say it. And so you keep faking it till you make it. And then a couple things happen. Either you make an error that could risk human life. And I can't say that strongly enough. I don't think it's said enough. You can kill people in this job. You can be responsible for their not living. And if you didn't do the right questions, you may not know the information. Then there's another phenomenon that happens. When somebody comes in and does know the information, you dismiss it. Oh, that's not real respiratory therapy. We don't do that in the real world. Hell, I haven't even looked at the alveolar autoclaves since I left school. Well, you suck. If you don't think about your A to A gradient and what that even means, you suck as a respiratory therapist. You suck as a nurse that doesn't know that fluid overload into your pulmonary capillaries and alveoli and that system sounds like expiratory wheezing because you don't know the flow of the heart because you faked it too long. You didn't ask. All you heard was wheezing and you wanted to go and get a respiratory therapist to check the box for you that patient's being taken care of. You suck too. You faked it too long. But if you'd asked during that window where we expect you to be a sponge and ask more and learn more, and then you go find another thing that opens that window in another way. That's where I'm at. Every single day I'm opening a window saying, how can I do this better? And if I don't know the answer, I go ask someone, hey, I get confused. This is my goal for the year is I want to learn more about the loop of Henle and the way that sodium is released and not based on the diuretic you give. Because we all know respiratory therapists want a couple of things. We want you sedated and paralyzed, number one, on a ventilator. No, we don't really. But I'm just saying to make, as a joke, we don't really want those things.
No.
But we also ask for Lasix. Everybody wants Lasix, right? But there's other options and there's other reasons why and things to look at. And so that's my goal this year. And so I'm going to be a sponge and I'm going to ask urologists and people that I'm around to say, can you talk me through that again? Because just like I can talk about alveoli like it is like the back of my hand, I can make it very creative so you'll never forget that alveoli, look like bubble wrap. I use that all the time for my patients. I bring very simple things because I know it so well. I'm going to start asking other experts when I'm trying to learn something. And that window opens when I ask the question. And if I learn it, yay. If I fake it, that is going to hurt me. That physician may never teach me anything again because I didn't really absorb what he spent the time to teach me.
Yeah. I think it's great. I think the whole concept, and I think you're the first person to really ever put it in a context for me like this. Not just in this video, but in conversations we've had before. The fake it till you make it concept. Well, we'll talk about that in just a second. Let's recap what we've talked about. So Teresa said, let's be a sponge. She said, soak up every amount of educational opportunity that you have to soak up. That's what a sponge is. Now you're going to realize that this be a sponge concept, it's not the first time you've seen this on this channel. She said multiple times that you suck. And not just from the RT perspective, but also from the nursing and maybe even from the physician perspective. But if you are not taking care of your patients in the manner at which they need to be taken care of, she's exactly right. You suck. And if you're okay with that, then just be okay with it. But just be able to admit that you suck. And that's one thing it is. Now, she did say, do not fake it till you make it, because faking it till you make it leads you to a point of actually a lack of knowledge. It leads you to a point to where I've gotten by and I'm now a 3, 4, 5 year RT veteran. And I'm like, oh, I'm good. Everybody sees me as the veteran now. But because you faked it for so long, you never learned what you should have been learning. So you have to, according to Teresa, and just think about it. Like this is literally, this is a saying actually, fake it till you make it, that is so common in everyday education of respiratory therapy, but it is the worst advice you will ever receive. If you fake it till you make it, you're never really going to make it. Because you're really not going to know what it is to be talked about. And
think about this. If you were able to fake it till you make it and it worked, who are you surrounding yourselves with? It's not eagles. It's a bunch of turkeys.
Yes, you're exactly right. Oh, I love that. It's not eagles. You want to be with eagles. You don't want to be with turkeys. 100%, Teresa.
Yeah.
Thank you for that. Teresa talked about this idea of respiratory therapists doing the minimal work for the maximal pay and then expect a level of respect. And that's never going to happen. You're never going to get the minimal effort for the maximum pay and then get maximum respect. It doesn't work that way. So keep that in mind. She said, watch the errors. Look out for those things. She talked about when she was in school, and she said, you know what? Now that I'm not in school anymore, what I look back on is that the things that are important to me now were the things that I was not taught in school. And she is now in an educator position, and she's throwing those things out there. So think about those things. And this is true not just for Teresa right now, but probably many of you RTs and future RTs in class of 2021. You guys are graduating therapists. There's going to be new stuff that you weren't taught. So you have to stay up with the education. Don't forget respiratory rates, the #1 vital sign. I circled it 37 times. Why? Because it's literally that important. As Teresa stated, the respiratory rate is the #1 indicator of a problem. So pay attention to your respiratory rate and do not let it go. Egos, they don't have a place in this world. You, as an RT, are an important cog of the wheel. I love the way she said this. Cog of the wheel. Think about that. You probably never heard that before. I've never heard that before. You're an important cog of the wheel, and you have a role to play. So play that role and be an important cog to the wheel. We're going to be practitioners. The bachelor's degree, nothing is going to really lead to more money. It's all about education. And at the end of the day, we're not really talking about money. Like, let's just be real here. We're talking about human lives on the line, and it's not about the money you make. So associate's degree, bachelor's degree, master's degree.
I have to say, I want to interject 1 second right here.
Yeah, go ahead.
I'm probably not going to make more money by getting my master's, but there is soon, at least the way I intend to lead the rest of my career and the careers for people that come after or now, is I don't think that there will be advancement in respiratory therapy the way that there were in the past 30 years or 50 years in my career without an advanced degree. You need more time understanding the advanced science behind the advanced concepts we're practicing at the bedside. It's no longer okay to just know how to do it. You really are only going to be valued if you know why and take that to the next level. And in that way, those practitioners, I do believe, will make more money.
Yeah, I think you're right. I don't think there's much more money to be made right now in advanced degrees, but I do think they're coming.
Mm-hmm. I agree with that.
And ultimately, I don't even care. Ultimately, let's be real here. You could be an associate's degree practitioner. You can make $60,000, $70,000 a year. You can have a bachelor's degree and make $80,000 a year. You can have a master's degree and make $90,000 a year. There's no difference in those levels. It's no difference. It's not like one's making 60 and one's making 150 and one's making 230.
Mm-mm.
It's not. It's not. And I'm going to say it, and I've said it before, and I'm going to say it again. Getting and obtaining an advanced degree, a bachelor's degree, a master's degree, let me tell you what that means to me. It means that when I go to work and I work alongside of Teresa Griego, and she has a master's degree, then I know that no matter what problem comes up, we together have the tenacity to figure it out and to beat it. That's it. That's all it means. I don't care about money. I don't care about salaries. I don't care about anything. All I care about is the fact that the person I'm working alongside of, my soldier in the battle, is willing to go to the same level that I was willing to go to.
Mm-hmm.
And has the tenacity that I have. That's what it comes down to, right, Teresa?
I agree.
Like, that's all it comes down to.
I think education is a exercise in tenacity.
Yeah, that's all it is.
And when you get the degree, first of all, you advance your knowledge along the way, but also you have a degree saying, I stuck it out to be better, to teach others, for the people that follow. Yeah. Right?
Yeah, it's not this idea of stopping at an associate's degree. And I just do want to say this real quick. I know we're getting kind of long here, but that's okay because it's my channel, so I can be as long as I want. I do agree that I don't think there's a big difference between associate's degree and bachelor's degree in the term of skills. What I think the difference is and where it comes into is culture and research. And those two things right there, and tenacity, and those things right there make it a different playground. We're not playing with the same kids.
Well, because the associates is average now, and we're not trying to be average, right?
That's right. That's right. We're going to get there in just a second. Teresa started this conversation off a long time ago by talking about either the therapy works or it doesn't. And that is a big statement. It's the very first statement I wrote down throughout this process of listening to Teresa and conversing with Teresa. Look, if your therapy isn't working, find something else. If it is, then congratulations. But if it's not, find something else. And finally, average is easy. Don't be it. Learn from these people that I'm pulling onto this channel to share with you their insight and their thoughts and the expertise that they have through many, 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 many years. And you can learn from these years. So the last thing I want to do is this. If you found any value in this video, anything that Teresa said, hit the like button. Tell me if you have any questions, put your comments below. If you found also any value in this, hit the subscribe button. I'd love to have you in the community. And finally, I'm going to turn this over for Teresa to finish this off. Now, Teresa, you got the final word. And also, people want to know where they can reach you if they want to reach out to you.
My final word. I think I said it in this whole thing, right? Breathing is the first thing we do and the last thing we do in this world. And both of them are holy. So don't take that position of helping people with it lightly. It's a big, beautiful responsibility.
Teresa, whenever you get your merch built up, that's your t-shirt. Breathing is the
I don't know
first
about merch.
and the last thing. Do you have a way that people can contact you?
You can always email me at teresagriegorrt@gmail.com.
Very, very good. Thank you so much for your time. This was so fun for me. I don't know about for you, but for me, it was so fun just to hear and interact with you. And I appreciate you for your time.
Thank you. I'll see you soon.
All right. We'll talk to you soon.
Bye.
Bye.